Hello everyone, today we'll be going over Mycobacterium and TB infection, as well as its treatment, its ripe therapy. So get right to it with Mycobacterium. What can you guys tell me about some features of the Mycobacterium species?
It's acid fast, carbofusion stain.
Bacilli.
It's virulence factor's cord factor.
Okay.
Macrophages. It infects
Granulomas in the macrophages.
Macrophages, causes granulomas.
Okay.
Reduces release of TNF alpha.
Alright. So, all true, all good. So I'm going to go through what I wrote down. We have gram-positive rods / bacilli. It's an obligate aerobe, and facultative intracellular, acid-fast, like you guys said, and is sensitive to UV light. Its cell wall is important. It's very waxy, has a high concentration of mycolic acids, which make it resistant to drying and many other chemicals that are used to kill other bacteria before culturing and all of that stuff. Some distinguishing features is that on aramine rhodamine stain, it shows up as fluorescent green. And there is another stain called Lowenstein-Jensen medium, where it can also grow on, but this takes about 2 to 3 weeks, some say 3 to 6 weeks even, depending on your activity. Mycobacterium also produces niacin and also produces heat-sensitive catalase. And this is important because when doing a standard catalase test on a medium, for example, it's going to show up negative. But it will produce catalase that's going to be active at body temperature and do all of its fun stuff inside. Reservoir being your human lungs. And transmission, does anyone know?
Transmission? Airborne?
Yeah. It's going to go through your respiratory droplets. And then here's an image of an acid-fast staining with a very weird shape going on, but that's just what your acid-fast stain kind of looks like. It's nice and red. Okay, so if Mycobacterium had been included in this little chart, it would show up right there in this guy. So your gram-positive, bacilli, aerobic down there. Okay, so a little bit about its pathogenesis. Mycobacterium has some important things that we need to look at. So in the cell envelope, there are things called sulfatides or sulfolipids, and these guys are important for inhibiting phagosome-lysosome fusion. So this allows intracellular survival of the organism. And then we have, like Tulsi said, cord factor, also known by another name as trehalose, pretend that's right, dimycolate. This causes serpentine growth in vitro. And this guy is important because it inhibits leukocyte migration, disrupts mitochondrial respiration and oxidative phosphorylation, and also secretes TNF factors here as well. And then we have the tuberculin surface protein and mycolic acid. These guys are responsible for the type 4 hypersensitivity reaction you see in a diagnostic test, which we'll talk about a little bit later. as well as cell-mediated immunity, where you have granuloma formation and caseation as well. And also important to note that there is no endo or exotoxin with Mycobacterium. The damage is primarily done by the immune system. And then we have first aid's little grouping here. So let's get this going. So apart from Mycobacterium tuberculosis, which we're all very familiar with, we also have within the species other important mycobacteria like Avium intracellulare, and this guy causes disseminated non-TB disease, especially in AIDS and other immunocompromised patients like cancer patients and those with chronic lung disease. And this guy, important to note, it occurs with CD4 count less than 50. You can start prophylaxing with azithromycin because that's where this guy usually occurs. And then we have Mycobacterium scrofolaceum, and this presents with a cervical lymphadenitis in children. You'll usually see a solitary cervical lesion there, and this can occur from contaminated water sources. And also know that these two are both respiratory. This guy is from water. And then you have Mycobacterium marinum, known for causing hand infections or soft tissue infections in aquarium handlers. So this is also known as fish tank granulomas. So that's important to know. And this occurs with if there are abrasions on the aquarium handler's hands. They can get infected with that. And just again, we already talked about it, but all mycobacteria are acid-fast. So you can see these guys right here. These are your little Mycobacterium. Here are your little pink rods that show up there. And some symptoms for TB infection, especially this guy, include fever, night sweats, weight loss, cough, and hemoptysis. And then we see cord factor here again being important as a virulence factor. And infection with mycobacteria will activate macrophages, promote granuloma formation, and then you have release of TNF-alpha. And then again, your sulfatides, like I mentioned before, will inhibit phagolysosomal fusion. Alrighty, so any questions on that before we move on to tuberculosis infection? Nope. Okay. So, how does TB present? I kind of mentioned a few of the symptoms we'd see on the last slide, but any other things you guys want to shout out about how TB presents?
Fever, chill, hemoptysis, weight loss.
So with active TB, right, you'll see fever, chills that I didn't include on here, but night sweats, hemoptysis, cough, weight loss or anorexia, chest pain, fatigue. On physical exam, you can hear abnormal breath sounds, especially over the upper lobes. You can also hear rales or bronchial breath signs as well. Another thing to note is that TB doesn't only occur in the lungs, it can disseminate to other tissues. So if it's extrapulmonary, you can see a whole host of other symptoms. Chest pain can progress and lead to acute pericarditis. You can see leukocytosis and anemia and hyponatremia from ADH release from lung tissues. You can lead to tuberculoid meningitis leading to coma. You can see pot disease when it enters the vertebrae, causing back pain or stiffness, and if untreated can lead to lower extremity paralysis, and so on and so forth. You get the idea. It causes a lot of symptoms all over the body if it leaves the lungs. So, just a little bit about how this disease process occurs. So in primary infection, you have organisms replicating in alveolar macrophages, and the macrophages and the organisms are fighting each other, and the organisms are trying to kill off the macrophages until cell-mediated immunity occurs. So this is where you have a gone focus coming along, and I'll explain in visual form a little bit later. After which, macrophages will transport the bacilli to a regional lymph node. So the combination of these two things going on is called a gone complex. And most people will generally heal without progression to active disease. And organisms are walled off within the gone complex, and if they're stuck there, they'll remain viable unless they are treated with medications. So then we have reactivational tuberculosis, which occurs when granulomas can be eroded into the airways later in life. This usually occurs under conditions of reduced T-cell immunity, and that'll lead to the replication and disease symptoms progressing. And again, if the disease process becomes complicated, it has the potential to infect other organ systems and can disseminate, and that is known as miliary TB. So, now for me to draw this fun stuff out for you guys. So we have, just a regular healthy person walking around. They're exposed to someone who's been coughing up some bad TB molecules, and then they inhale them in here, getting into your lungs. And TB likes to infect these fissure regions. Let's see if it kind of draw it in there. It's kind of sort of see that there, or the subpleural regions as well. Let's clear that out real quick. So we have all of these alveoli at the end of these branches. Can't really see. Well, we'll just pretend this is one giant alveoli that we have blown up here. So what you'll have is your macrophage eating up your organism inside there. And this macrophage can travel up through your airways into a lymph node, your regional lymph node here. And then you'll also see within here your macrophage with your organism inside. So with a primary infection, which is what we're going to see here, you are going to see a granuloma formation going on. And within that granuloma, let me change the color here, you're going to see caseation going on inside. And this is a form of necrosis that's occurring. And this guy right here is known as your gone focus. And the combination of this focus and then the same process going on in your lymph nodes, these two together, is known as your gone complex. Okay, So does that make sense so far with your primary infection?
Good artwork.
What did you say?
I said good artwork.
Hard to see drawings there. Okay, so over time, your TB infection can do a number of things. So it can, let's draw these arrows here. It can either die off, it can be dormant, I'm going to draw that with a couple of Z's here, or it can multiply. Shine your multiplication sign there. So, if the disease is progressing and multiplying, you will see lots of disease process going on in your lung here, in that area of the gone focus and potentially spreading, as well as in your lymph node. In the dead phase and the dormant phase, so this is actually on chest x-ray, what it's going to look like. So in the multiplying one, you're going to see lots of processes going on that'll show up on your chest x-ray, but your dormant and your dead phase are going to look normal. And these two are known as your latent infection. I'll pretend that's a letter L there. Okay, so these two can be differentiated by what is going on in their alveoli, and this is actually even smaller than just looking in the alveoli and seeing granuloma formation. We're looking intracellularly. You're not going to see any organisms here. But here, you'll still see some TB organisms hanging around. That's how you differentiate these two. These bacteria are live. They're just sleeping. Okay. And just to give additional names to things, this guy here is also known as progressive primary infection. So keep that in mind, because over time, even more time, we'll see progression into secondary infection, and this one's also known as progressive secondary infection. And this usually occurs after years of infection. And what you're going to see here is a cavitary lesion. So this place is going to be empty, but you're going to see disease process in the lung all around that cavitation. And then this is also known as reinfection as well. You can also get a far less common secondary infection if you had been exposed to TB in the past and then you're re-exposed to new TB for the second time. It can also lead to this progressive infection. And yeah, so any questions about this mess of drawings before I move on? Okay. So on chest x-ray and CT, I just wanted to show you guys what it would look like. You can see these infiltrates going on in particular regions of the lung. You see you have an apical focus there, and then you have a big old cavitary lesion with consolidation on the outside. And then this guy is this whole lesion there. So just so you have an actual visual of what it looks like in patients. All right, so now that we know what it looks like and how it happened, we want to know how to diagnose it in patients. So there are a number of things you can do. You can take a sputum sample and do the auramine rhodamine stain that I talked about earlier. And if it's positive, it'll show up as fluorescent green. And you can confirm the diagnosis with an acid-fast stain. Another thing you can use is a PPD skin test. So this is going to measure the zone of induration. So if you have someone's wrist over here, the size of this red bump after they had been injected with the stuff. And then 2 days later, they'll see how big this guy is. So a positive test would occur if this guy is greater than 5 millimeters in HIV positive or recent exposure patients. So they have, you see, compared to the other numbers, a far smaller size because of their very, very high risk. And it's also important to note that AIDS patients will have a reduced ability to mount the skin test. So that's something to note there as well. It's going to be positive if it's greater than or equal to 10 millimeters in high-risk patients. That includes IV drug abusers, people in poverty, immigrants from high TB areas, and well, us med students. And then in the general population, greater than or equal to 15 millimeters in low-risk general population. That's what we look for there. And a positive PPD skin test indicates exposure, but will not indicate whether the disease is actually active or not. Other things you can use for diagnosis include the quantiferon TB gold test. And this guy measures the interferon gamma production when leukocytes are exposed to TB antigens. And then, like I mentioned before, there's the Lowenstein-Jensen medium, but this guy takes 2 to 3 weeks, maybe even up to 6 weeks in some cases. And there are obviously faster systems now, so don't really see this guy too much. And also remember that it produces niacin and catalase, so you can also look for those as well. And note that it's catalase negative when doing at 68 degrees Celsius and is active within the body. So keep that in mind as well. And there's no serodiagnosis for this guy. Okay, and then we have first aid's little image. So go through it one more time. We have our gone focus, which is our infection here with our macrophages containing our organisms as much as they can, and when it spreads to the hilar lymph nodes, these two together make up your gone complex. And this is your primary TB infection. It can, like I said before, progress in primary tuberculosis. So this is that bottom lung image that I did before. Can cause progressive lung disease and bacteremia, and can also spread to other parts of the body, and that's known as miliary TB. Or it can heal, causing fibrosis and calcification as well. And here you will see tuberculin positive tests there. It can reactivate after a number of years, causing your secondary tuberculosis. And this is where you'll see your cavitary lesion, which usually occurs in the upper lobes. And that can progress to further destruction and also cause dissemination into the rest of the body. And again, what I mentioned before, less commonly, you can also see a second infection of TB. Very unlikely, but it's still something that could occur that can lead to secondary tuberculosis. And again, PBD positive is looking for exposure. It's important to note that it can be PBD negative not only if there's no infection, but in cases of sarcoidosis or HIV infection will affect that test as well. And just kind of an image of what the caseating granulomas look like. This is kind of the edge of the cell. You have all of this central necrosis going on, and then there are your giant cells right there. And let me make that clearer. Just so you can compare it to a non-caseating granuloma in sarcoidosis, you see this little empty area that somehow people think look like cheese. I don't personally see it, but there, that is. So you can tell visually. Okay, so any questions about all of that information before we move on to how to treat this guy?
I think the caseating, is that more of a gross pathology thing than a... Oh no, I'm thinking necrosis. Never mind. Moving on.
Anybody else? Any questions? Concerns? Okay.
I guess my only, not question, but my only comment is when it's calcification in the primary, is that called Ranke's complex or Rank's complex? Or is that wrong? Like when you heal by fibrosis and then it causes that calcification, is that called Rank's complex or Ranke's complex? I don't know if anybody, I have that on my notes, so if anybody knows.
Yes.
Here's Sandra talking about that.
That is correct.
Okay, so that, okay.
So if it's healed from primary tuberculosis, so we're not talking about anything down here, just at this level.
Yeah.
And has the two components, so it has both the hilar nodes and the GON focus. That's when you call it Ranke's complex, because it's a complex. So the whole complex has to be healed. And then you have, I'm not going to write it out, but Ranke's complex. But good question. Okay, so now on to treatment. So this is also out of first aid. We have kind of different treatments for different mycobacteria. For example, with tuberculosis, you can use isoniazid for prophylaxis and then RIPE therapy for actual treatment. And then for MAI, you have azithro and rifabutin for prophylaxis, and azithro or chlorithro plus ethambutol. You can also add rifabutin or ciprofloxacin as well for treatment. It's a little more drug resistant, so requires a little extra oomph. And then Mycobacterium leprae, which I did not talk about today, does not have any prophylaxis treatment, but can be treated with dapsone and rifampin for the tuberculoid form, and you can add clofazimine for the lepromatous form. And since you're adding something, this guy's obviously the more serious of the two, so it's just a little extra information for this guy here. And just so you can see where these guys work, isoniazid is going to work in the cell wall. It's going to affect mycolic acid synthesis. You have ethambutol also working in the cell wall, but in a different area. And then you have your rifampin and rifabutin working within the cell, as well as pyrazinamide. We're not really too sure what it exactly does, but just know that it's intracellular, because that can also come up in questions where it's working. So, we'll go through a little more information about these guys. I know we just saw it, but can anyone tell me the mechanism of the rifamycins, rifampin, and rifabutin?
DNA-dependent RNA polymerase. It inhibits it.
Yes. It inhibits your DNA-dependent RNA polymerase. Again, we use it for TB and can also use it for leprosy, as well as meningococcal prophylaxis in contacts of children with H. flu. So that's extra stuff there. Can anyone tell me the adverse effects?
Hepatotoxic. And then orangey fluids.
Yes.
Orange tinge fluids.
Correct. CTC. Let me draw these out. Hepatotoxicity. Note the cytochrome P450. Increased metabolism there. And then the orange body fluids. And so you can also note this little way to remember rifampin's information by the 4 R's. So RNA polymerase inhibitor. It ramps up your cytochrome P450 system. Red-orange bodily fluids, and there is also note rapid resistance if used alone. So monotherapy. That did not come out as a straight line. Monotherapy leads to resistance, which is why we want to use this in combination with other medications for TB treatment. Okay. Also note that rifabutin does not ramp up the cytochrome P450 system as much, so it's favored in patients with HIV infection. Okay, then we have isoniazid. Can anyone tell me what isoniazid does?
Inhibits mycolic acid synthesis.
Yeah. It decreases synthesis of mycolic acids, and it's important to know that isoniazid needs a bacterial catalase peroxidase to become active. And this is encoded by something called CatG, which is important because TB can resist by having mutations that underexpress that CatG, so your isoniazid won't be able to become active. It's also important to know that this is the only agent that is used as a solo prophylaxis against TB and can be used as monotherapy for latent TB. And can anyone tell me the adverse effects?
It's a P450 inhibitor. Drug-induced SLE, hepatotoxic. Peripheral neuropathy. Yeah.
Everything you said, hepatotoxicity, P450 inhibition, drug-induced SLE. Also note the anion gap metabolic acidosis, as well as a vitamin B6 deficiency, which will cause, like you said, peripheral neuropathy and sideroblastic anemia. So you want to administer with B6 to help prevent that. And fun little line to help you remember, INH injures neurons and hepatocytes. So that's there. And then we have all these other guys that I smushed together on one page. We have pyrazinamide, like I mentioned before. The mechanism is unknown, but no, it is intracellular. And this guy is also gets converted to an active compound called pyrazinoic acid, and works best at an acidic pH. Does anyone know the adverse effects for pyrazinamide?
Hepatotoxic?
SLE induced drug.
That was isoniazid. So pyrazinamide has hepatotoxicity as well as hyperuricemia. But we care more about hepatotoxicity here. Because if you're taking this drug in combination with isoniazid, both of these drugs cause hepatotoxicity, so it can be one on top of the other, you're just making it worse. So these pyrazinamide and ethambutol are discontinued after a certain amount of time to avoid that. And then we have ethambutol, whose mechanism, can anyone tell me?
Block something, yeah.
So this also works at the cell wall by blocking arabinosyltransferase, which will, like, go back to this picture here, which will decrease the arabinogalactan within the cell wall. So that's a important and very long word to know there. And does anyone know the adverse effects for ethambutol? I left that guy up there for a little clue.
It's the red-green color blindness.
Correct. Red-green color blindness. And then we have a second-line medication, streptomycin. Can anyone tell me the mechanism for this guy?
30S subunit.
Yes, 30S subunit. So this guy is an aminoglycoside, so you see those ototoxicity stuff going on. Okay, tinnitus, vertigo, as well as nephrotoxicity and ataxia. Yeah. So any questions about the drugs before I move on to quiz you guys?
Nope.
Okay. First question. A 4-month-old girl is brought to the emergency department with fever, irritability, and vomiting for the past 2 days. On exam, she is ill-looking, lethargic, and febrile. Blood cultures grow Mycobacterium tuberculosis. One of her brothers died from disseminated mycobacterial infection during infancy. Impairment of which of the following protective mechanisms is most likely contributing to this patient's infection? Antibody production, complement production, interferon signaling, isotype switching, or leukocyte adhesion. No, it's TB. One of her brothers died from disseminated infection during infancy. And one of the protective mechanisms is impaired.
See?
Okay. Anybody else?
Maybe D. I don't know.
Okay, we have a guess for C and a guess for D.
A and D are kind of like the same thing. I don't know, I'll make this for B.
Good question.
answer is C. So, let's see what order I did this. Okay. So when we think about TB, we think about granuloma formation. And granuloma formation also deals with interferon signaling, primarily interferon alpha. So if you have Mycobacterium tuberculosis in a family like you see here with girl and her brother, especially during infancy, you want to think about an impairment of this process. So your TB is not being localized, it can spread, causing a disseminated infection. So that's important there. With antibody production, you'll can see that impairment happening in, for example, a gamma globulinemia, where you can't produce IgA, for example, so you'll more likely see a Giardia infection rather than TB. With complement production, you're concerned primarily about the MAC complex, so you would be more likely to see a Neisseria infection going on. And with isotype switching, similar to antibody production, you're just unable to produce IgEs or A's, things that you wouldn't normally see initially. And what's important here is the CD40 mechanism there. And then with leukocyte adhesion, your classic sign for this is the umbilical cord stump not falling off here. And what's important here is CD18 and cutaneous lesions occurring. Any questions about this guy? Okay, our next question. A 52-year-old Asian male presents to your office with cough, night sweats, and occasional hemoptysis. Sputum cultures placed on a selective medium grow Mycobacteria microscopically, observed to grow in parallel chains, known as serpentine cords. This observed bacterial growth pattern most strongly correlates with acid fastness, growth rates, virulence, pigmentation, or survival in macrophages.
Yeah. See?
I
Okay,
agree.
got 2 for C. Tulsi?
I agree too.
C is correct. So what are we referring to here?
Okay.
Yes, cord factor. This guy is important for neutrophil inhibition, mitochondrial destruction, and induced release of tumor necrosis factor. So important thing here is your parallel chain serpentine cords. This happens in vitro, not IV, in vitro. And last question. A 63-year-old man comes to the physician because of recent weight loss, cough, and occasional hemoptysis. His past medical history is significant for poorly controlled diabetes mellitus and chronic obstructive pulmonary disease treated with bronchodilators and oral corticosteroids. Chest x-ray shows pulmonary infiltrates and an area of cavitation in the right upper lobe. Sputum microscopy shows acid-fast bacilli. Which of the following is the most accurate statement concerning this patient's pulmonary infection? First exposure to the bacilli occurred recently. Healing of the lung lesion would result in Gone complex formation. It originated from reactivation of an old infection. It was facilitated by low levels of protective antibodies. Negative tuberculin skin test would signify strong cell-mediated immunity.
C.
One for C.
Yeah. Don't steroid.
Another one.
I agree with C as well.
C is correct. So, it's also important to note here that you can see with the chest x-ray findings, you have the pulmonary infiltrates and an area of cavitation, especially in the right upper lobe. So when we're talking about cavitation, we know it's not a primary infection. And what most likely is occurring is that there is a reactivation of some old infection going on with your active symptoms here. So on first exposure, you wouldn't see cavitation. Healing of the lung lesion, you wouldn't see the active symptoms. Low levels of protective antibodies, you'd be concerned with immunocompromised patients, as well as here, specifically in AIDS patients. This is where that note I was talking about came earlier, that you can have a negative tuberculin skin test with severely immunocompromised patients, as well as those with a very strong cell-mediated immunity. And, just so you know, cavitation, secondary tuberculosis. And that is all I have for you guys.